Good afternoon, respected delegates, doctors, and faculty members. I'm your virtual host, Samruddhi. I welcome you to AIOC 2021. To begin with our third session of the day, I would like to invite Dr. Namrata Sharma to initiate the session. Over to you, Doctor.
So thank you so much. We have been doing this session for many years now, and this is a paradigm shift in microbial keratitis. Basically, how evidence has changed the way we practice the microbial keratitis, and there are talks in this session, so we will be going through them one by one. I would be talking to you about workup of case of microbial keratitis and the bacterial keratitis. The fungal keratitis would be dealt by Dr. Samar Basak, Director, Disha Eye Hospital, Barrackpur, Kolkata, from West Bengal. Viral keratitis, Professor Ritu Arora, Head of the Cornea Department, GNEC, more importantly, Dean of the Maulana Azad Medical College, New Delhi. And then I would be talking to you about acanthamoeba keratitis of the triumph permis and therapeutic keratoplasty. And then we'll be joined in by Dr. Rajesh Pogla, who's going to be talking about blue and deep anterior lamellar keratoplasty in microbial keratitis. So in this bacterial keratitis only, I will cover the workup of a case of keratitis. There are no financial interests or disclosures, and this is essentially how a classical case of Pseudomonas bacterial keratitis would look like. And these are the risk factors. So the risk factors can be ocular or they can be systemic. The ocular include the corneal abrasion of the epithelial defect, eyelid disease, use of contact lens, previous ocular surgery, ocular surface disease, the compromised corneas, and also the injudicious use of topical antibiotics, corticosteroids, or traditional eye medicine. Now, the risk factors could also be systemic. So these include the use of immunosuppressive drugs, burns, chronic alcoholism, severe malnutrition, AIDS, malignancy, and rheumatoid arthritis, and extremes of age, which include the infancy and the old age. These are some of the pictures to show keratitis after use of traditional eye medicine such as honey. Then this is used because of the use of steroids. So notice there's so much of thinning here and perforation here. And this is a post-LASIK keratitis, a buttonhole flap, and an edematous LASIK flap here. So the symptoms are redness, sensitivity to light, which is increased, or photophobia, visual acuity, which is decreased, pain, discharge, and associated conjunctivitis, which may be associated with gonococci, pneumococci, or Haemophilus. And it is important to do a good slit lamp examination to see the area and density of infiltration, size and depth of ulceration, size of the epithelial defect, degree of stromal edema, scleral involvement, or AC reaction. Now, it is always advisable to do a photo documentation of these cases so that you know how these cases follow up. But in case you do not have a photographic follow-up, you can make a diagram, draw a diagram, so that when the patient comes up for follow-up, you know where the patient is. Now, this is just to show that you have to not only measure the size of the epithelial defect, but also the size of the infiltrate, which may be different from the size of the epithelial defect. And each time this as well as this have to be measured. And when the patient actually changes his position, then there may be the mobility of this hypopyon, and the fungal hypopyon is fixed, whereas the hypopyon due to the bacteria is mobile. And the grading of the ulcer is important, which could be mild, moderate, or severe. So mild is less than 2 millimeter, moderate is 2 to 5, severe is more than 5. Likewise, the depth is less than 20%, 20 to 50%, more than 50%, and infiltrate extent could be superficial mid to stroma or deeper than mid stroma, and the scleral involvement when there is none or when there is severe. So depending upon this, the treatment would go both for bacterial and for fungal keratitis, and that is why you should know the grade of the ulcer. Now, it was been clearly shown that the ulcers with a poor outcome are likely to be larger, and they involve the posterior cornea, and they have the aspergillus species, or they occur in females. So this is just to highlight the features of severe microbial keratitis, how they are going to behave. Then you have classical pictures like that of Staph aureus. It's compromised, occurs in compromised corneas with local distinct borders and non-edematous surrounding cornea, absolutely clear cornea on all sides. Then you have pneumococcal species, which is rapidly progressive serpiginous ulcer with folds in the desmoid membrane, hypopyon, and deep stromal abscess. Then Pseudomonas species, which has got ground glass stromal appearance, fulminant green yellowish discharge with infiltration, which occurs in 24 hours with a hypopyon diffuse epithelial grain. Ring ulcer, which occurs in 48 to 96 hours, desmetocele and perforation, which occurs in 2 to 5 days. And mycobacteria species or atypical ulcers tend to occur after trauma. They are indolent. They have a classical cracked windshield appearance, which you can see here. The surrounding cornea is quite clear, and there is hardly any AC reaction. So again, this is a cracked windshield appearance which can be seen. The Moraxella ulcers, on the other hand, tend to be inferior. There is hardly any AC reaction. They are oval. They occur in diabetics, alcoholics, and malnourished. And the Nocardia ulcers have indolent or elevated hyphae edges with cracked windshield-like appearance. Satellite lesions are there, and they have a classical wreath-like pattern. Clinically, the clinical examiners can only predict what microbiologically the ulcer looks like only in about 3/4 of the cases. So microbiology remains the mainstay for all cases of microbial keratitis. So in all such cases, when you're doing the scrapes, it is important that you avoid the cotton swabs. Proparacaine can be used because that's the least bactericidal. Scraping should be done from the leading edge of the ulcer and from the center, and modified Kimura spatula may also be used. One can use gram stain and KOH, and most important smear is going to be KOH. So the grams will identify bacteria, yeast phase of dimorphic fungi and fungal hyphae as well. KOH will identify only fungal hyphae, and the acid fast is for man, that is Mycobacteria, Actinomyces, and Nocardia. Diagnostic culture media, for the cultures, it has to be sent, and the standard culture media is blood agar or chocolate agar, saprotes, dextrose agar for fungi, and apart from this, there can be supplemental media, so mycobacteria for LJ media, and acanthamoeba non-nutrient agar with E. coli. Of the bacterial cultures, the positivity rate is 40 to 73%, and everything which is related to this, including the contact lens solution, case, sutures, everything should be sent for culture. But sometimes the infiltrate may be like this, so you will have to actually remove the sutures and get the scrape out, or it may be a infectious crystalline keratopathy after LASIK flap, so you have to elevate this flap and take a scrape. At times it may be there in desect, such as this, so you may have to take an intravitreal scissors and get that little bit piece of tissue out to send it for culture sensitivity. And sometimes there is an abscess present, so you may even do a short suture biopsy, take this needle through this and then send it for culture and sensitivity. Corneal biopsy is advocated for at least twice negative smear and culture with no clinical improvement. Partial thickness trepanation is done, and the tissue can be removed en bloc and can be dissected. Treatment strategies for mild ulcers and moderate ulcers are different. So if it is a mild ulcer less than 3 millimeters in size, not involving the visual axis, a monotherapy can be given with any of the fluoroquinolones. But if it is a moderate ulcer more than 3 millimeters in size involving the visual axis, then combination therapy has to be given, which is fortified cefazolin with tobramycin 1.3%, which should cover up for both the organisms, that is the gram-positive cocci and the gram-negative bacilli. So loading dose of monotherapy or combination therapy should be given round the clock for the initial 48 hours. And then you have to assess the clinical response in case of bacterial keratitis after 48 hours. These were the two randomized control trials that we did comparing moxiflox with the combination therapy in microbial keratitis for mild to moderate ulcers, and likewise gatiflox with combination therapy involving 200 plus patients. And this is again a study which looked at 1,823 subjects, 16 studies. This was a meta-analysis, and they found that there was no difference in healing, especially for mild to moderate ulcers. And when they didn't use a combination therapy, there was increase in ocular discomfort, chemical conjunctivitis, and white precipitate of ciproflox, which was increased. So for mild to moderate corneal ulcers, one can use fluoroquinolone, but for severe ulcers, one has to use combination therapy. Apart from this, the adjunctive therapy can be used in the form of cycloplegics, anti-glaucoma medications, and topical steroids. And this, of course, is a double-edged sword, and we'll be discussing about the steroids in the case of bacterial keratitis again. Systemic antibiotics, on the other hand, are required for perforated ulcers or impending perforation, post-perforating injuries, scleral involvement, or when the organism is Neisseria and Haemophilus. Now, the Scar-to-the steroids for corneal ulcer trial clearly showed that you can give topical steroids, and early use of topical steroids is especially beneficial in cases of low vision, in cases of central ulcers and deep ulcers. And non-nocardia keratitis and severe Pseudomonas keratitis did better when topical steroids were used. So suffice it to say that topical steroids can be used in case some of the cases, provided you have a culture report in hand, provided you've already loaded a case of bacterial keratitis for at least 48 hours with the antimicrobials, and provided you are absolutely sure that the ulcer is not nocardia, not atypical mycobacteria, and not fungal. So in all such cases, the topical steroids may be used. Now, the favorable signs will be when the area and the density of the infiltration decreases, the epithelial healing happens, the AC reaction decreases, and can modify antibiotics only if there is no clinical improvement, but taper when the clinical signs of improvement are there. Unfavorable signs are when there are problems of compliance, resistance. Then should look for other organisms like atypical bacteria, herpes, fungus, and protozoa, and other factors like dry eye, vitamin A deficiency, and exposure. Now, this is just to show when you need to change your antibiotics because it is not responding to the ones you have already given. Then these can be used in methicillin resistant staph, that is vancomycin, Pseudomonas keratitis, ceftazidime, Mycobacteria fortitum cheloni, amikacin, and clarithromycin systemically, Nocardia, amikacin or trimethoprim, sulfamethoxazole, and systemic trimethoprim as well as sulfamethoxazole. So this is just to show how we prepare cefazolin and how we prepare tobramycin for all those who want to understand how it is done, and the preparation of the vancomycin from the powder on how it is done, and then amikacin is given directly from the intravenous uh, injectable form which is available. And then for trimethoprim or sulfamethoxazole, we use 16 milligram per ml and 80 milligram per ml. Then in cases which are resistant to everything, one can even use topical colistin 0.19%. And this is how it is prepared with 10 ml of distilled water to yield a concentration of 0.75%. And then you finally get to a concentration of 0.19% after further diluting it. So this is how your case should be. With each time you have to do a fluorescein staining, and it should lead to a corneal haze and response of the ulcer. And sometimes what can happen is that the patient is not resolving due to non-compliance. So when the patient came here, he did well. The size of the ulcer is decreasing, so is the hypopyon here. But notice the patient stopped medications at this point in time and again has come back to this. So compliance is very important and it should be ensured at all follow-up 5 points. Apart from this, if the ulcer really doesn't respond, then there can be complications like perforation here, like corneoaradic scar here. This is going into impending perforation. Then you can even have anterior staphyloma. So this is something which we should try to prevent. Then the surgical management indications are impending perforation, and when there is no response, one should to reduce the microbial load, and the modality could be glue, patch graft, or therapeutic keratoplasty, and I think we shall discuss this later. So early diagnosis and meticulous treatment are mandatory in cases of bacterial keratitis, and compliance and resistance are important issues in the event of non-resolution. Antibacterial should be used judiciously, and surgery may be required in recalcitrant cases. So thank you very much for your kind attention. And I don't think there will be any questions. So we can probably move to the next talk. So the next talk is going to be viral keratitis or fungal keratitis by Dr. Samar Basar.
Is it visible now?
Yes, sir.
So,
slideshow, sir.
okay.
Thank you, sir.
Okay, thank you. So, thank you, Dr. Namrata, for again same topic for last couple of years. We are doing this instruction course. My talk is on fungal keratitis, the standard treatment and the role of intrastromal and intracameral injection. So you know that fungal keratitis is mostly reported from the developing countries, and mostly they are reported from tertiary care eye hospital. And in tertiary level, standard treatment of fungal is always based upon microbiology workup. On the other hand, in small clinic, most of them are the primary cases, and many situations the treatment is empirical. But for empirical treatment, it is always difficult because you need more knowledge about the morphology of ulcer, etc., etc. So knowledge about the geographical location, like I always said that Aspergillus is more common in Eastern India and Fusarium in South India. Similarly, there are urban and rural patient variation. Also, the vegetable matter injury, like paddy versus onion. Onion is more of Fusarium than the paddy, which is more of Aspergillus. So you need to know the what is the sensitive pattern of that particular region. So empirical treatment is difficult, but primary care physician should start empirical treatment, but should be rational and see the response for maximum 48 to 72 hours. Then if the response is good, he can continue the treatment. Otherwise, we need to do a microbiology workup and other support in a tertiary hospital. So guidelines are there from AIOS, and second guideline also has come. So there are definite good, the algorithm and what to do, what not to do, everything is there. So in the antifungals, we have basically two groups, Pauline and Azole. In the Pauline, we have both the drugs, natamycin and amphotericin B. Amphotericin B, we need to prepare it, but natamycin is only drug that is commercially available at 5%. And we have Azole, the iconazole, ketoconazole, and itraconazole. Nowadays, you know that posaconazole is also a concern. So it is using for mucormycosis also, not for keratitis. Similarly, the in vitro sensitivity pattern, if you see that different antifungal has got different sensitivity pattern. Amphotericin B is only best sensitive in Aspergillus, Candida. But whereas if you see natamycin is most sensitive in Fusarium and other, also it is there. Voriconazole is sensitive, but alone it is not that sensitive and like other antifungal. Key points to remember that all available antifungals are fungistatic, not fungicidal. Natamycin is the drug of choice in filamentary keratitis, especially against Fusarium. And due to poor penetration, it is only effective in non-severe and more superficial keratitis. And every time when you use the antifungal, we need to scrape so the drug penetration is better. Amphotericin B is effective against Candida and Aspergillus, and fluconazole also shows some in Candida species. So role of scraping and debridement is also there. On first visit, it is a must. Then repeat scraping depending upon the response and also the microbiological report. So helps in decreasing the microbial load, as I said earlier, that it also helps in penetration of topical antifungal. But in dermatitious fungus, where you see black plaque, that it is very difficult to scrape. So, and the penetration of the drug is less. So you probably need every visit or every alternate day for drug penetration. So there are two kinds of therapy. For first thing, initial management always starts with monotherapy. Superficial ulcer less than 1/3 depth and no or trace hypopion. And then the natamycin half an hourly for the first 24 hours, then 1 hourly. Or amphotericin B or voriconazole Sometimes natamycin is not available due to this pandemic situation. So we need to give either any of the three. Sometimes you are desperate to give this kind of drop. And also, if you use natamycin, it is so sticky, so thick. So ask the patient to clean the eyes before putting the second drop. So you see that bleeds are stuck, and naturally the second drop probably will not work. So that is very important point. Then other than that, cycloplegic antibiotic. And then initially you have to review this patient every alternate day or third day, then weekly. And depending upon the response, you have to taper the dose or you have to go for combination therapy. MART trial, this is very breakthrough trial, and they have shown that voriconazole as a monotherapy is not very effective in filamentous keratitis, especially with fusarium. In vitro susceptibility of different antifungals that they have also studied in different way, and you have to actually use the wise combination. That way, natamycin or voriconazole, so one Pauline group and one azole group, you have to use it for better sensitivity of that organism. Then the combination therapy, especially useful for one-eyed, more than 5 millimeter, deep ulcer, presence of bigger hypopyon, scleral involvement, and maybe after 10 to 14 days when you see that your monotherapy fails. The combination of natamycin voriconazole may be better. Otherwise, amphotericin voriconazole can be given. But amphotericin and natamycin are not synergistic because the both are in the Pauline group. Role of systemic antifungal is there. So fluconazole, ketoconazole, itraconazole or voriconazole, and systemic toxicity of oral antifungal should also be kept in mind. So you have to go for liver function tests after some time. So MART trial 2 also showed that if you add oral voriconazole, it doesn't actually very much helpful for fungal keratitis. Then how long is to continue the antifungal treatment? Till the complete healing of the ulcer. It is difficult to judge, especially with filamentous fungus, but the rule of thumb is continue for another 2 weeks, maybe 4 to 5 times, when you have all the signs of ulcer healing. And also ask the patient to come after 2 weeks, because sometimes the finer filaments might stay in the angle and they may, again, there will be recurrence or relapsing of the ulcer. Targeted therapy is also like intracameral and intrastromal. So we can give targeted therapy, and first you have to remove this hypopyon, then you need to give intrastromal around the ulcer. So give from all directions so that it should surround the ulcer. Then there are indications like deeper ulcer, endothelial plaque, and there are fixed doses. But there are conflicting reports among these antifungal intrastromal or intracameral. Intracameral, the RCT trial by Namrata et al., they have shown that it is not very effective with or without drainage of hypopyon. But we had done initially some of the cases, and some of them are with good response. Similarly, intracameral voriconazole, but it doesn't have much role because if you see the half-life, it is only of 22 minutes. Then, but they are using, the retina people are using intracameral voriconazole for endophthalmitis, and sometimes we use in post-keratitis endophthalmitis along with intracameral and intravitreal voriconazole. Role of this intracameral and intrastromal voriconazole, again, there are a lot of reports on either side if you go to the report literature. But again, regarding the topical and intrastromal, very interesting article by Namrata et al., they showed that that additionally it doesn't cause any effect. So you may combine intracameral and intrastromal voriconazole, and some of the cases this might help. So in summary, in some studies shows that it does work, but complications are there like uveitis, secondary glaucoma, iris neovascularization, that is very important, and subsequent bleeding during therapeutic PK. So there are also report of like if there is interface small infiltrate, you can treat them with intrastromal. This is the TST protocol, topical systemic and targeted protocol. This is published in Cornea Journal last year only. And you see that Namrata, they have shown beautifully, and they have given the beautiful algorithm how will you proceed, and with huge number of cases. So these are very important, and if you go they follow this algorithm, you will be successful in most of the cases. So take home message is timely standard medical treatment is the key to success in most cases. For smaller superficial ulcer, monotherapy with amphotericin B or natamycin. Natamycin is most effective is fusarium. Amphotericin B is most effective in Aspergillus candida. Voriconazole is less effective in fusarium. Combination therapy with Pauline and azole may have synergistic effect. Intracameral and intrastromal you have to give according in case-to-case basis with patient with deeper ulcer and with endoexudate. Thank you very much for your patience.
Thank you so much, sir. Ma'am, would you like to give some comments or say something?
No, I think you both have done beautifully covered everything, and it still stays the most difficult part to treat this kind of a keratitis. And better is to follow it up with microbiology, because microbiology support is very essential, and that guides our treatment. And seeing the patients maybe frequently, every 24 hours or 48 hours in the initial phase, also helps in the better management of these cases. Otherwise, the problem of fungal treatment with ampho, voriconazole, natamycin still stays the same. It's a very difficult field, but yes, can be managed if we combine, as Dr. Basak has talked.
So thank you.
I have a question. Mane, just
Yes,
your
sir. Yes, sir.
experience, what is the do you think that the fungal keratitis has increased during this pandemic or vice versa?
I think it has decreased. What do you think, sir? Has it increased?
No, if
Maybe
you
we don't
see
get that many cases.
probably they are not coming to tertiary hospital.
Yeah, they are not. For us, they are.
But if you see in the lockdown period, only thing work is our agriculture. And GDP actually positive side on agriculture. So what we are seeing nowadays after gradual lifting of lockdown, in fact, the fungal ulcer, whichever happened, they come with devastating results of fungal. So actually it may, I do not know, but LV Prasad, they have done one study and they had shown that yes, fungal is actually more percentage-wise, not in absolute number, percentage-wise it is more.
It may also be related to the over-the-counter antibiotic steroid eye drops, which
yes,
getting, if they have an eye problem, instead of seeking out a consultation with the eye specialist, they would have just been medicating with antibiotic steroid drops, which leads to worsening of the fungal keratitis.
So there are two questions for you. One is, I think it's MV, so I'm presuming it's Dr. Vanity. But one is, what is your experience with the newer antifungal agents such as casprofungan? And
no idea.
Only in very resistant cases when nothing works, we do try to.
And these are actually so expensive. The posaconazole, I know one of our consultant is getting after post-COVID, and it is so expensive. Per day expenditure is so per tablet is 4,000. So posaconazole, I know I read 2-3 reports that it is very recalcitrant cases of fungal corneal ulcer you may add. But Caspi fungal is, I do not know whether available, but posaconazole is available in India and it is hugely expensive.
And the next question is if we do antifungal sensitivity testing. So
No,
I think none of us do.
I don't think it's going to work.
Yeah.
it's only in vitro people are trying to see the sensitivity report of.
Okay, so with this, we'll move to the next talk by Professor Ritu Arora, and that's going to be on viral keratitis. And after this, I think I would request Dr. Fogla to speak, and I would speak in the end. So, ma'am, please.
Yeah, my 1 minute. I was open, but I can't see my presentation. Just
Ma'am,
a
please
minute.
click on share screen, ma'am.
Yeah. Share screen. Yeah. Yeah. Can you see my slides?
Yes, ma'am. Please slideshow, ma'am.
Yeah. Can you see the slides?
Yes, ma'am.
Yes.
Yeah, so as always, we've been doing this course for so many years now. And thank you, Namrata, for inviting me for this particular course and be part of this team. And I would be talking about viral keratitis and attaining the right balance, because very often we have issues related to diagnosis and then going on to the management. Viral keratitis specifically, it differs from bacterial and fungal keratitis because they are usually chronic, recurrent, they're frequent relapses, unlike bacterial and fungal keratitis, which once resolved stay like that. And initially, it was thought that they are uncommon in the developing countries, but it's not so. They're quite common, and they're painful. They're sight-threatening infections. They may be epithelial, but they also have recurring stromal and endothelial components. And they very often have morbidity due to corneal scarring and neovascularization, because of which they affect the quality of life when patients are not experiencing active infections. And the virus usually is latent in the trigeminal ganglion. And this is the way a typical dendritic keratitis, which may present. And as we always teach the undergraduates that more symptoms, less signs. So slit lamp examination becomes mandatory. And typically a dendrite looks like this, a branching dendrite with terminal bulbs. And I've just put this picture just to say that a case which came to me and on treatment, once picked up, on treatment, this is exactly the picture at 48 hours. And this is how the lesion heals properly. And this picture, this is in between. Once, how do we know when the dendrite is healing? You can see that the extent of the dendrite tends to diminish over the period of time. Clinically, it's important to know whether the virus we are treating with infectious epithelial keratitis, or is it the stromal element which is more, or is it the endothelitis, or it is the uveitis, or it's a keratouveitis, or it's a neurotrophic keratitis. So important to know what element of the cornea is more affected. If it is infectious epithelial keratitis, it may be presenting in the form of a dendrite, or it may be a geographical presentation. If it's stromal, it may be disciform or necrotizing or interstitial keratitis. Then endothelitis, which may be associated with deep stromal keratitis. And it's not uncommon to say only uveitis or keratouveitis and neurotrophic keratitis. Once we know what form of keratitis we are dealing with, the treatment becomes easier. Because when it is epithelial keratitis, we don't use steroids, and it's when the stromal keratitis, the benchmark is steroids. This is a typical geographical ulcer which presents. It may present like this feature, so it's like an amoeboid kind of an ulcer. And as you can see on the slit, there is occurring a defect over here, and underlying cornea is edematous. And so these are the different phases when the healing takes place. Herpetic stromal keratitis, infectious epithelial keratitis, virus is actually multiplying in the epithelium, and that's how the stromal keratitis differ. It's primarily an immune response to the epithelial disease, and very often we see the epithelial keratitis and stromal keratitis coexisting. And it is usually an epithelial response to HSV, which is in the anterior stroma, or which is present in the nerves. It may be non-necrotizing or a necrotizing inflammation. And in non-necrotizing, you usually have an intact epithelium. So when you stain, you will get stain negative. There is a focal or a diffuse multifocal associated with anterior uveitis, which may be typically in the form of a disciform keratitis. And a necrotizing stromal keratitis is invariably in the form of as if you have pus in the cornea, very severe necrosis, there's ulceration, and there is dense infiltration, and eye is very inflamed in those cases. So you may have a difference whether to differentiate whether you are dealing with a bacterial keratitis. And here, HSV DNA may be present, while I've seen few cases of necrotizing keratitis when you get a severe inflammatory response, and it may result in thinning and perforation. So this is what a typical viral stromal, this is the right and the left eye of the patient. And quite often you may mistake, because this was the left eye, patient had been operated for a simple corneal scar. And you can see that there is present a clear graft, operated PK, while the patient was being treated. The right eye presented with this kind of a simple corneal edema, and there are present KPs on the endothelium. And this is when the patient went on to the healing stage, the edema goes down and may leave a simple scar. This is how a necrotizing keratitis presents. When we have some, you may feel as if it's like a pus kind of a thing present in the cornea, and there is present an epithelial defect. It's highly inflamed. Dense stromal infiltration is there. There's ulceration, necrosis, and this is due to direct infection of the corneal stroma with severe host inflammatory reaction. So these are the cases where primary treatment is oral antivirals. We may have a presentation in the form of a deep stromal keratitis, which may amalgamate with endothelitis, where we get these kind of folds in the decimus level, and there is present endothelial edema associated with it and KPs. And a deeper layer of the stroma is affected. It is not associated with any epithelial lesions. So again, it will be stain negative, and they have a prolonged course. And as I told you in the beginning, the bugbear is a recurrence. So recurrent stromal keratitis, we've had cases which present to you at times with edema, and then 2-3 months later, they may come to us with saying that my vision has gone down. I have plenty of these bilateral patients following up with me. And then when you look at the edge, there may be another edge where there will be edema, while another edge where it will be just a simple corneal scar. This is the fellow eye of the same patient, which you can see the slit through different areas, and there is a fusiform edema over there. So this is another patient, which is a recurrent multifocal keratitis. One area is scar, while I've just tried to take the slit through multiple areas just to see that what we are dealing with, because that area which was initially affected has gone into a scarring stage, but there's another area affected with very, very severe edema. And these patients are like usually have 2x60, 3x60 vision. And yeah, Namrata, I will be needing a little bit more time. So when recurrent viral keratitis may present to us with the kind of a dendrite at times, and which may present a dendrite, and it has to be treated. Herpetic endothelitis may present in this form when there is a deep stromal edema, and they, as you can see, they have KPs, which we see on the indirect illumination, whether it is an immunological reaction to virus or it is a cytolytic effect of the virus on the endothelium. And we treat them, these patients, by giving oral antiviral, 400 or 800 mg 5 times a day with steroids when they're stain negative, which they are usually. And at times they may go, these endothelitis may lead to a permanent endothelial failure, and they may need endothelial surgeries. This is another patient of mine who had had a multifocal done outside. 1 month down the line, she presented with the diminution of vision. And here you can see that she presented with this kind of a localized edema, and there are present decimus folds. Basically, she had presented with endothelitis post-successful multifocal surgery. This is another presentation of a neurotrophic keratitis when they have decreased corneal sensation and tear production. And the treatment here is only lubricants, patching, tarsorrhaphy, or autologous plasma growth factors. So why I'm highlighting over this again and again, just to know which layer of the cornea is primarily affected, and the treatment is directed according to that. This is a resolved ulcer and which may leave a thinning over there. The commonest presentation which we have is a combined presentation. So we evaluate, is it the epithelial layer affected, or it is the stromal layer affected, or the both affected. So as long as the patient is stain positive, we do not use topical steroids in these patients. Another not so uncommon condition, when you may operate a phaco on a simple corneal scar, or I've had patients have had glaucoma surgery with corneal scar, and post-op steroids are given, and then there is a flaring of the viral keratitis. They may be secondarily infected with hypopyon. This is another a patient of mine who was following up with me for a long time, which presented with a small kind of an infiltration over here. And this is the same patient over the period of time, kept on, did not respond, had an interstitial keratitis, and eventually leading to secondary infection. Though patient was being put on oral antiviral, and I had to do a scraping through that, which just did an inflammatory cells. So as far as different studies which have been done, which are hepatic eye disease study 1, which said that topical corticosteroids, it significantly improves the stromal keratitis. Oral acyclovir is beneficial in the early resolution of stromal keratitis when used as an adjunct, and oral acyclovir is beneficial in the treatment of iridocyclitis. And there are certain specific indications of using oral acyclovir, which I will be coming on to that. And in a case which we are following of epithelial keratitis, if you start the patient on oral acyclovir, there is no additional benefit that it prevents stromal keratitis or iritis during the subsequent years. As far as when the recurrence is there, a hepatic eye disease study 2 said that long-term suppressive effect of oral acyclovir, 400 mg BD. We really do not know for how long to use. Some of my patients on lifelong oral acyclovir, but we have to start in case of recurrent. We start them, and as for a year, it definitely reduces the recurrence of HSV, epithelial, and stromal keratitis. And it is greatest effect seen in patients with prior stromal keratitis. And the triggers have been known to be the trauma through surgery, injury, or any laser. And in HIV infection, when you have is more than 3-fold increased risk of developing ocular herpes simplex virus. Other treatment options are topical TFT, topical, of course, ASV already I've told you. And then there is ganciclovir and oral medication. There is valacyclovir, and this is the important slide which I want everybody to see, that the role of systemic antiviral in heads is that antivirals are useful in the prevention of recurrent episodes of herpetic stromal keratitis. It has a very slow half-life. I mean, it stays in the system for long. Therefore, oral acyclovir is used 5 times a day. And valacyclovir can be used an alternative to acyclovir because it has a little longer half-life, and this is used TDS. So I've given the equivalent. If you have 800 milligram of acyclovir 5 times a day, it is equivalent to 500 milligram of valacyclovir TDS. In cases when you are on maintenance dose of acyclovir 400 mg BD, it is equivalent to 500 milligram valacyclovir OD, and famciclovir 250 or 500 milligram only TDS can also be given. So these are different permutation and combinations whenever your patient says that they don't want to use the drug for a longer period of time. Another one which we have is the topical ganciclovir. It does not have any extra advantage over using acyclovir, except that this is to be used less often, TDS, and rarely in cases which are resistant to acyclovir, ganciclovir may be of use. Whenever we do a PK in a case of earlier herpetic stromal keratitis, there are higher risk of glaucoma rejection, graft rejection, and disease recurrence. And of course, the role of latency is herpetic latency is the lax, which when they are given, it can reduce the incidence of recurrence. So thank you very much. So ultimately, we need to have a balance when we have to have a diagnosis, what layer is affected, balance as far as topical or systemic antiviral is to be used, balance when topical steroids are to be used. Some of the cases of herpetic uveitis present with simple glaucoma, and you just need anti-glaucoma agent, lubricants, dosage of systemic antiviral, and acyclovir or valacyclovir in surgery. So balance of all these things can lead to a very, very successful and a happy patient. Thank you very much.
Thank you so much, ma'am. I think, like I always say, this is the atlas of viral keratitis. And we also learn so much by your presentations. Something or the other new comes up, in each of the presentations. Rajesh, would you want to say something?
No, I think she has beautifully covered all aspects of viral keratitis.
Thank you.
Wonderful.
Ma'am, I think there are a few questions in Q&A section if you would like to answer them.
Yeah.
So what are the questions?
So post-COVID related keratitis or post-COVID immunization related keratitis?
I have yet to see any post-COVID keratitis, maybe mainly because we are still not open. We're still not open, so I don't think I'm the right person to comment. But post-COVID immunization keratitis, as I look at it, will be mainly inflammatory and it may not be infective. I have only seen 1 or 2 viral keratitis after the first phase, and which could be successfully managed. I will not like to comment about viral element in that.
Thank you so much, ma'am. I would, Dr. Basak sir, would you want to give your comments on viral keratitis? Otherwise,
No, it is fine. It is fine. Lovely talk.
it is always a pleasure to hear this talk. Next, I would like to invite Dr. Rajesh Fogla to give his talk on glue and therapeutic deep anterior lamellar keratosis.
My slides are visible?
Yes.
Yeah. At the outset, I would like to thank Namrata for making me part of this course. The topic is glue and DALK in microbial keratitis, no financial interest. The glue commonly we use is the cyanoacrylate and used for clinical cases when during the course of treatment of infective keratitis, there is thinning and there is a perforation. Like in this case, you can see it's sedal positive. The glue polymerizes on contact with fluid. So if you continue to have seepage from the perforation, the glue application can be unsuccessful. So for this, what we do is we place an air bubble in the anterior chamber using a 30 gauge needle. Once you place the air bubble, then you have the surface can be made dry. You can see that now there is no seepage of fluid. It's important to debride all the surrounding loose epithelium or exudate that's kind of sticking with the around the ulcer. Otherwise, the glue will not get a firm hold. And the application of glue, there you can see we are removing all the loose epithelium and the debris sticking. The glue is applied on a small circular disc, which can be refined with a 2 millimeter punch. And then you can apply that disc onto the cornea. That ensures that your anterior surface is pretty smooth. Although the glue can be applied directly, but that tends to leave a slightly irregular surface. Then you can either leave that disc behind or remove it and then place a bandage contact lens. So that's how you take a cotton swab, cut it, and then apply some ointment at the tip. And then you can pick up the disc of plastic that you have created with the punch and then apply a little bit of glue and then bring it to the point of application. So the same patient you can see in the post-operative period, there is good healing. Glue does bring in some vascularization, and you can see the post-operative patient. This patient went on to have 6/18 vision and did not require a corneal surgery. However, in advanced cases, you need to do a surgical procedure. Commonly, we used to do penetrating keratoplasty when there is no response to maximum medical therapy, rapid progression, or the tectonic integrity is compromised. Let's look at the rule of anterior lamellar keratoplasty. The advantage is that you retain the host endothelium, thereby you can have long-term survival of the graft and no need to use long-term steroids. The disadvantage could be that if you leave behind the residual stroma with the infective material, there can be increased risk of recurrence of the infection. The advantage is you are doing the surgery in a closed globe, so the intraoperative complications associated with the open globe can be minimized. So there have been some reports. This is the earliest report that we saw published back in 2002, but they were using it for cases as early as 7 days after the medical therapy. We know that for fungal keratitis, on an average, you need to give therapy at least for 35 days or more before you can see a complete resolution. They had mostly filamentous. So I think the successful outcome could be the superficial nature of the fungal infection in all these eyes. This was a paper published from Italy from Dr. Sarnicula's group. They also performed DALK in eyes with fungal keratitis. Here also the infection was not exceeding 300 microns. So basically in the anterior half of the cornea, they performed big bubble in 74% of the eyes, so that you go all the way up to the predecimates layer, removing most of the stroma. They had a good outcome and they did not have any graft failure or rejection during the follow-up period. Another paper from China and from Bascom Palmer, where they looked at performing big bubble DALK in deep fungal keratitis. So the cornea was almost 4/5 of the cornea was involved in the fungal keratitis, and they performed big bubble, which goes all the way to predecimates layer. They did have DM perforation in 2 eyes, but they continued the surgery by placing an air bubble. They had favorable outcome, only about recurrence in 2 eyes of 8.7%. This is one of their cases where they show there is significant amount of central visual axis involvement where the DALK was performed successfully. A nice study from Singapore National Eye Center by Donald Tan, where they compared therapeutic penetrating keratoplasty to therapeutic DALK. Both eyes achieved a similar therapeutic success. However, the full thickness therapeutic keratoplasty, when they had recurrence, almost 50% of them had poor visual outcome. The best corrected visual acuity and the long-term survival, the therapeutic DALKs outperform the therapeutic keratoplasty. Some of their cases, they show post-operative photographs showing the good outcomes after the lamellar graft. And this is one case where they showed there was a lot of exudate present within the interface, which was sterile, and finally with medical therapy, the graft finally cleared, leading to good outcomes. So don't go by the early post-op. You have to differentiate between a sterile hypopyon and a recurrence of the infection. This is again for acanthamoeba keratitis. We know that medical therapy can sometimes be ineffective. So in this case, after between 30 to 60 days of medical therapy, when the ulcer was not responding and it was involving only half the corneal thickness, they performed DALK, out of which they were predecimatic, that is a big bubble DALK in 4 and near decimus dissection in 7, and they had good outcomes in all these eyes. I also had a similar patient where non-responsive to acanthamoeba keratitis. We went ahead, we were planning to do a penetrating keratoplasty because it was going quite deep, but then we decided to try and attempt a DALK procedure. As we injected the air, we did get a bubble, but we were not sure as to what type of bubble we achieved because the whole stroma had become emphysematous. So after debulking the anterior stroma, when we looked at it, we can see here what the sharp margin, unlike the dense margin, what you see with the type 1 bubble. So this was a type 2 bubble. We released the speculum, make the eye very soft, injected some cohesive viscoelastic, knowing that a type 2 bubble, the decimus is very fragile and can easily rupture. But we were able to maintain the intact decimus membrane, complete the removal of the anterior stroma, and then place a graft and secure it in place. So when you are deroofing a type 2 bubble, you have to ensure that there is minimal upthrust, and you have to repeatedly release aqueous to keep the eye soft and make sure that your instrument does not come in contact with the decimus membrane. So this patient had a good visual outcome. You can see there is good resolution, but the medical therapy has to be continued post-operatively because there will be some residual infection that's left behind. And if you don't give the anti-amoebic therapy, the chances of recurrence can be high. This is another case with not responding to acanthamoeba keratitis that was successfully managed using DALK. Similarly, microsporidial keratitis, we know that we don't have an effective therapy. So DALK can also be used in such cases to perform the surgery. So this is again a patient with non-responsive treatment where big bubble DALK was performed. So you can see that a successful type 1 bubble. So the advantage of big bubble is it removes all the residual stroma, and thereby it can eliminate all the infected tissue from the cornea. This is again a patient who had a smile performed and then ended up with an infective keratitis. So here also a big bubble DALK was performed with a good post-operative outcome. This is again, once the infection is resolved, you can sometimes have corneal thinning, perforation, which was managed with the blue and amniotic membrane. Patient was recommended for a full thickness graft. We did a DALK, and this is how the patient did. Despite having a 2 millimeter perforation, a DALK can be performed with good outcome. So in conclusion, therapeutic keratoplasty may be essential to eradicate infection, But the advantage of DALC is that it avoids endothelial rejection and late graft failure. Timing of intervention is critical. Surgical planning also depends on the extent of involvement. Perioperative antimicrobial therapy is necessary to prevent recurrence. Thank you. Thank you for your patient hearing.
Thank you so much, Rajesh. I think therapeutic DALC does have a role to play, and it should be done, like I say, always the therapeutic keratoplasty, and I'm sure you all will agree, should be done earlier than later. And if you keep it for a later date, then there is every chance that it may, it may involve the sclera, and then things become almost non-salvageable. So, any comments from Dr. Basak sir and Dr. Ritu?
Yes, no comments. Yeah.
No, he's
videos.
dealt with a very difficult topic in a very lucid manner.
No, but again, one of the things that is required is often these grafts are going to be larger in size. So if you're going to do a DALC, do it under general anesthesia, because under local anesthesia, if you have a complication, it can become difficult to manage because you may have to convert to a penetrating keratoplasty. Surgery may get prolonged. And if you're going to do a DALC, make sure that you have some experience of doing the DALC surgery. Don't take up a therapeutic DALC as your initial cases.
So with this, I think I will go to therapeutic keratoplasty now. So therapeutic keratoplasty is something which we all have to do, and in I don't know about other places, but lots of our residents also do therapeutic keratoplasty. They are tougher to do as compared to optical keratoplasty. I always feel that residents should first be given optical because of the fact that you have hot eyes. So you need senior people doing it, and you need good grade corneas to do it, which we don't do. And I know when I did my fellowship in UK, it is the other way around. They are using good grade corneas, and they are being done by the senior people there. So the goals of therapeutic keratoplasty are surgical debridement of infected tissue, elimination of the microbial load, maintain the globe integrity and diagnosis of the infective pathology, and provide a visual rehabilitation. And indication for the therapeutic grafts are corneal perforation, impending perforation, treatment of the refractory ulcers, prevent the involvement of the adjacent sclera, and decrease the risk of endophthalmitis. If we look at the microbiological diagnosis at our center, and this is the data which was way back in 2014. Although I know that in bacterial keratitis, you should not be requiring so many therapeutics, but being a tertiary eye care center, whatever the organism we get, all the late cases only. So almost half of the cases were bacterial or fungal, and culture negative cases were about a third, for which we had to do a therapeutic keratoplasty. It's important to do a good history taking, because by the history itself, you can do a differential diagnosis, a general medical evaluation, ocular evaluation, which can be done on slit lamp in relation to the limbus, especially because that will determine the size of the graft, the intraocular pressure, which is important. And of course, ultrasound B scan should be done along with the checking of the PL and PR, so that you know that there is some prognosis there. It is important to do a good general medical evaluation, because most of these cases, if they are perforation or impending perforation, may be required to be done under general anesthesia. Preoperatively, whatever the etiology of the microbial keratitis, one has to give the antibacterial. So topical and systemic therapy will be directed towards the offending microbe. Then topical antibiotic therapy may be given to prevent the bacterial superinfection. And indication of the oral antimicrobials is if there is any limbal involvement, if there's an intraocular spread, impending perforation or perforated corneal ulcers. And in all cases, one may also give intravenous mannitol, especially the impending perforations, to cause vitreous detergescence, 5 ml per kg. It is important to have good akinesia, anesthesia. So local anesthesia is given with peribulbar injection, 2% lignocaine, plus 0.5% bupropion with hyaluronidase. A subtenon block may be given again using the same. And in large perforations, one may require a general anesthesia. In all cases, in developing countries, there is a paucity of good quality donor tissue. So one may have to use a B-grade tissue. which doesn't have a very good endothelium, or else in the COVID times we've even used glycerin preserved corneas because there was no cornea absolutely. However, if the optical grade tissue is available, then the advantage is that it gives you a better graft survival, and it also permits the monitoring of a post-op AC reaction. These are the various steps of the surgical technique, which I will be dealing with one by one. So you apply a self-retaining speculum, avoid excessive external pressure on the globe. One can put Flarenga ring to provide scleral support. Peritomy has to be done, especially if the ulcer is large, and hemostasis is achieved with the wet field cautery. This is followed by the trephination of the recipient bed, and the size of the trephination is important. It should be 1 millimeter more than the size of the exudation. Side port entry can be done. The AC can be filled with the OVD, and post trephine is at least 1 millimeter larger, or 0.75 to 1 millimeter larger. And lamellar separation of the corneal layers is done instead of en bloc removal of the host. Then it is always best to do a partial thickness trephination so that you do not suddenly decompress the anterior chamber and it's a guarded anterior chamber entry. And if there's entire cornea which is involved, then you may even have to do a freehand dissection and excise all the necrotic and the infected tissue. AC reconstruction is extremely important in these cases, and all the inflammatory membranes and the infective membranes over the iris has to be removed or dissected.
Okay. I found this on the web for construction is extremely important in these cases and all the inflammatory.
And apart from this, the viscoelastic injection should be done in the angle at 360 degrees, and intracameral antibiotics or antifungals may be given whenever required. And it's good to do peripheral iridectomies, at least one or if possible two, because it prevents angle closure glaucoma. So this is a case of case which is not responding to medical therapy, has also perforated, being done under general anesthesia. Peritomy is done, AC entry is then done, and measuring the size of the exudation so that 1 millimeter more than this is the size of the trephination. And then guarded entry is being done because you don't want to do a entry which is you don't want to do a entry sudden entry, because that will cause decompression of the globe. And as much of the iris as possible should be preserved in this procedure. Of course, the lens is there. It is best left alone in a therapeutic keratoplasty unless it spontaneously expulses out. Then this is a case of regraft again, where peritomy is being done because you really can't make out anything much. Then this is followed by the hemostasis. This case looks very bad. And then layer by layer again, the exudates and the membranes are removed so that the underlying iris can be seen. And in all these cases, what happens is that there will be fibrin formation. As soon as you remove these inflammatory membranes, the fibrin will immediately form. So a large graft is taken, and this is then sutured with 10-0 monofilament nylon sutures. And one can even tuck the edges onto the ledge which was there, and this is the end of the case. Now, removal of the lens should always be deferred because lens is an effective barrier to prevent the spread of the infection to the vitreous. And lens removal in cases with concomitant endophthalmitis may be done, but it is always best to constrict the pupil and prevent spontaneous expulsion of the lens. Open sky vitrectomy may be required in aphakic patients or when suddenly the lens pops out because of raised intraocular pressure, and also when there is concomitant endophthalmitis when intravitreal antibiotics are given. Now, after the excision of the post cornea, the donor tissue can be prepared. Of course, there can be some controversy in this, that you prepare the donor tissue first, because otherwise there are chances of expulsive hemorrhage also in these cases. And measure the recipient bed diameter with the caliper before trephining the donor cornea, and additional trimming is then done. And again, you go 0.5 to 1 millimeter larger than the host defect. The graft host apposition and suturing is done using 10-0 monofilament nylon sutures going up to at least 75% depth. Now, avoid full thickness sutures because that will be a conduit for the passage of infection, and longer suture bites should be taken on the host side with moderate tension, and it avoids cheese wiring of the suture through the necrotic bed. Greater number of sutures for larger graft should be there to optimize the wound closure. As soon as you have this bit of tissue, this is cut into bisected or can be cut into 4 pieces, and then this is sent for culture and sensitivity as well as for histopathology, both for bacterial and fungal. Now, this is just to show another case. The size of the lesion is being measured here. Now, this tends to be eccentric. So an eccentric graft is being planned. The ringer ring can be used with the help of, can be anchored with the help of the vicryl sutures. And this is followed by the trephination, which is then done. And after this, there is a ledge which is present all around, which is removed, and AC can be formed, peripheral part of the AC can be formed with the viscoelastic. Peripheral radiectomy has already been done, and with the help of the 10-0 monofilament nylon sutures, the suturing is then done. If they're large grafts, you may have to apply more sutures. Of course, there can be problems such as lens extrusion, suprachoroidal hemorrhage, overriding of the graft host junction, and the loose suture, and the recurrence of infection. So this is the spontaneous expulsion of the lens, and then the graft is already ready in this case. Despite this, all the intraocular contents are being expulsed out, and that is something just to show how an expulsive can look. And this is the necrotic tissue is then being excised, and quickly the graft is being sutured. Of course, this situation should be prevented, but can occur. So what is the immediate step in this? The immediate step in this would be that you have to put a thumb there so that nothing comes out, and try to suture the graft as fast as possible. Because the post-op management, you need to give antimicrobial therapy depending upon what the organism is. The intraocular pressure needs to be controlled, control the inflammation. Epithelial healing should be encouraged with the preservative-free lubricants. Post-operative management would consist of something like this. So systemic antimicrobials or antibacterials, then topical antibiotics, and steroids can be given for cases of bacterial keratitis. 1 to 2 are initially under antibiotic cover for 48 hours. And then in fungal keratitis, we like to withhold for 1 to 3 weeks, following which these topical steroids can be given, provided epithelialization has occurred and provided there is no recurrence. In viral, they can be given under the viral cover. And acanthamoeba, again, one has to use the steroids with caution, and use especially only in cases where there is severe inflammation and severe uveitis or scleral involvement. So this is how the PHMB is prepared if you require it for anti-acanthamoeba as a part of the anti-acanthamoeba medications. Suffice it to say that for acanthamoeba keratitis, one should defer keratoplasty for as long as possible, because the chances of recurrence are very high. Now, the complications could be early onset or late, and I would be showing you only a few of them, but there could be glaucoma, suture-related problem, hemorrhage, persistent epithelial defect, recurrence of infection, and late onset could be glaucoma, cataract, graft failure, and phthisis bulbi. So these are the loose sutures. They should be immediately removed, because otherwise they would lead to recurrence of infection. And this is a loose suture with graft infection occurring at the place where the suture was loose. Then you can have hemorrhage or hyphema, and it is important that you use the topical steroids judiciously, and hyphema may need to be drained in some of the cases. Then there can be severe, it can lead to severe iritis also, and formation of a pupillary membrane. Because the raised intraocular pressure needs to be tackled with topical and systemic anti-glaucoma treatment. And if there are extensive peripheral synechia or late onset secondary glaucoma, then this can lead to a graft failure. Now, recurrence is known in these cases, and these are the figures which have been given for recurrence. Highest recurrence rates are reported after acanthamoeba keratitis and fungal keratitis, and one has to take that into account. Outcomes will depend on a lot of factors, and it is a high-risk procedure which demands a high surgical and medical skill, like I said initially, but more importantly, the story starts after you've already done a graft, because the patient is almost on a lifelong follow-up, There is a definitive role in the treatment of microbial keratitis refractory to the medical therapy, and advances in the microsurgical technique and newer generation antibiotics and control of inflammation may improve the prognosis. So this is just to show the outcomes, which I've also discussed earlier, but outcomes from our studies in terms of anatomical and functional success rate. So I think that is about it. Therapeutic DALG has been covered by Dr. Rajesh Fogla, so I will not be covering about this. And if there are any questions from the panelists or on the chat box, I will be very happy to take. This is our article on therapeutic keratoplasty, which was published in Current Opinions of Ophthalmology.
There is a question in the Q&A box.
One of the points that I find useful during therapeutic keratoplasty, especially to prevent that upthrust and spontaneous expulsion of the lens, because often you end up suturing a graft and have difficulty forming the anterior chamber, and that leads to peripheral synechiae forming and everything. So sometimes doing a pars plana, vitreous debulking, like a single port, just going to the mid-vitreous cavity and remove some vitreous, it allows you to do the surgery much more easily, especially if you're doing a larger graft.
And also in therapeutic keratoplasty, I always want everybody to have 8-0 handy with them. At times it becomes very difficult to suture with 10-0 and everything is coming out. So if you have 8-0 nylon handy, then you can at least give 4-stage sutures with that and then continue with whatever technique.
I think there is a question on a topic which we did not cover, so we can do a discussion on it, and that is adenoviral keratoconjunctivitis, because in fact all ophthalmologists have seen this condition and tried to treat it, and it is recalcitrant. So I would like to ask, what is your take on it, all the panelists, on management of adenoviral keratoconjunctivitis, and how would you manage it when it comes as a first episode, and how would you manage it when it becomes recurrent, and when you have nummular opacities, how would you manage it? So I think if we can take it in.
This is post-adenoviral subepithelial infiltrates are common, and I've seen at times patients they are started on oral antivirals or topical antivirals. Just want to say there is no role of topical or systemic antiviral in subepithelial infiltrates. I believe in early starting topical diluted steroids. And though when one withdraws, one knows that there is a very high incidence of recurrence that is there. But now few studies have come where you give topical steroids with betadine kind of, iodine kind of drops, and 0.6%. And recurrence has been reported to be a little lesser. But I don't hesitate in starting the patients on early topical diluted steroids with a close follow-up. And I've seen that to an extent has reduced the recurrences. And topical cyclosporin or tacrolimus, when added to that, also I've seen in some patients, but not always. It reduces the recurrence. But yes, it's a problem. Anybody else would like
Rajesh, would you like to comment on?
There have been studies which have looked at the role of topical povidone iodine in low concentration, especially in the early stage. It actually prevents the viral, basically the spread of adenoviral, especially in schools and all, if children get it. So if you start with these drops early enough, they have found that the transmission of the viral conjunctivitis can be lower. It acts only on the surface. So once you get nummular keratitis, I don't know whether povidone iodine will definitely play any role in that. At that point of time, depending on where these nummular opacities are located and what's the patient visual acuity, if they are not exactly in the visual axis and the patient does maintain a vision of 6/9 or better, then maybe reassuring them and giving them lubricants would be the first line of treatment. But if they have a drop in the visual acuity and it affects with their day-to-day working, they have photophobia while driving at night, then maybe starting them on low-dose topical steroids is indicated. But once you start it, don't be in a hurry to withdraw it. Then you have to give it over a long period of time. For me, that can extend anywhere from 3 to 6 months, because we have found that whenever you discontinue that, they will come back with a recurrence in 1 or 2 months' time. And yes, if you have patients where they are unable to take the steroid, then the tacrolimus ointment nighttime application does play a major role.
Dr. Basak is there? Dr. Basak, sir?
He has a course after this.
There's a course after this, probably even I thought as much immediately after this. So I think, and between cyclosporin and tacrolimus, do you think there is a difference? Which do you think is better in adenoviral keratoconjunctivitis?
I have not used cyclosporin in adenoviral, but yes, tacrolimus I have used because it's easily available in a single nighttime application. It does, like instead of using steroids, you can definitely use tacrolimus to try and manage the problem so that patients don't require long-term use of steroids. But again, this is not something, it's irritating to the eyes. A lot of people are not very comfortable using it long-term as well.
Somehow I've seen whatever a steroid can do, tacrolimus cannot do the same thing.
It's not the primary thing. I'm talking about more like a maintenance. Like once you have it under control, maybe to prevent those nummular opacities from coming back, maybe you can put them on tacrolimus. But once you have those opacities, definitely steroids will make them go away. And often we find that patients come with the thing that they are using either dexamethasone or Predfort, and they use that and the opacities go away like magic. But but it will come back the moment you stop. So we have to also warn the patient against self-medication, because we have had patients who keep applying these drops off and on, and they develop secondary glaucoma or cataract, and then it becomes more difficult to manage at a later date.
Do you think there is a burnout with the adenoviral keratoconjunctivitis? Or what percentage of the cases would you have seen that they have severely scarred after adenoviral conjunctivitis, so much so that it is causing, compromise in their best corrected visual acuity?
You mean keratitis or conjunctivitis you're talking?
I mean, nummular opacities.
Yeah, no, it's not that the vision goes down. It is the quality of vision which is quite affected. I've had a lot of, especially medical students and all, even postgraduates, when they get conjunctivitis, they end up with keratitis. So they have problem in driving. Vision is usually 612, 6.9. It doesn't go below that. But the quality of vision is quite affected.
Most cases, the visual acuity and the opacities also do disappear. Almost 90% of the cases. That's what I'm saying. But we've not seen those kind of cases which have, severely affected the visual acuity that way.
Yes.
It's not very common, but at a tertiary cornea care, you will have those cases which are not resolving present to you. So sometimes you may see those cases, which are not getting better. They have been going on for 1 to 2 years, and now they have opacities which may require you to intervene in the form of doing a small.
I was just wondering from that point of view. I don't think any of the cases that
I've not seen
required an intervention.
Even within the same family, not everybody gets the same response to the adenoviral keratitis. Sometimes you have everybody get it, but then somebody will develop a nummular keratitis and the rest of them don't get it. Even bilaterally, it's not symmetrical. Sometimes patients develop the adenoviral keratitis in both eyes, but you see the nummular opacity is more in one eye than the other.
Yeah. Somehow I feel it's got something to do with the immune response, like the COVID, not everybody gets the same degree of COVID. So,
yeah. And COVID also responds to steroids only and nothing else.
So that's what I feel. Yeah.
So I think with this, we will wind up, because there's going to be another course at 2 o'clock here on DMEC. So
thank you, Namrata, for inviting.
Thank you so much. Thank you so much, ma'am, for being a part of it. Thank you, Rajesh. I nearly thought you're not going to be there, and then I was I was delighted to see you.
How can I miss out on your course?
Thank you so much.
Thank you, doctors. It was a wonderful session. Excellent presentations by all presenters and wonderfully moderated by Dr. Namrata Sharma. We will conclude this session. Thank you for the time.
And let's hope we meet physically next time.